chose to call it anxiety, depression, and neurologic disease. I know that we're interested in brain tumors at this point, but a lot of the treatments that we use for brain tumors have their own set of effects, and a lot of those effects sort of mimic neurologic disease. So that's why, to encompass both the brain tumors themselves and the treatment and what that does to the brain, I thought neurologic disease sort of fits the picture a bit better. And that's me. And so there's a spectrum. So neurobehavioral sequelae means things that happen to our organic brain, to our mind, and then impact our behavior and our ability to function in the world. And there's many things that do that. So one is traumatic brain injury. So we traditionally think of traumatic brain injury as soldiers in battle, things like that, or football players. But if you think about it, anything that causes the brain shock and injury is considered traumatic brain injury, and that includes the brain tumor itself, which can injure tissue around it, and the surgeries and the treatments that we do. So a lot of the symptoms that patients have during treatment, after treatment, when they're recovering, definitely mimic traumatic brain injury symptoms. So I like to include that as part of our spectrum. Cerebrovascular. So that's usually stroke, either ischemic, where you have a clot that blocks the blood flow to the brain, or a hemorrhagic stroke, where we have a little bit of a bleed. And again, if you think about it in terms of the treatments that we use for brain tumors, these are things that are possible just from treatment itself. If we do surgery, we sometimes cut some of the blood vessels. We try not to, but sometimes we have to. And radiation can also cause changes to the blood vessels that can cause symptoms that mimic cerebrovascular disease. Neoplastic means cancer, and that would apply to the tumors themselves, whether it's a primary brain tumor or a secondary brain tumor, like a metastases. And neurodegenerative, and this one is really interesting. This is one that we are studying, but we don't understand fully yet, and that is, what is the toll that all of this takes down the line? And then the toll seems to, in some ways, resemble some of the neurodegenerative diseases that we already know about, such as Parkinson's, Alzheimer's, where there's a lack of certain neurotransmitters and changes to certain structures in the brain. So vulnerable areas of the brain. So this is something that I talk to patients about a lot, because I think people think that their brain after cancer should then come back to normal functioning. And when it doesn't, they really think of it in terms of anxiety, like feeling a little bit anxious or having a panic attack, depression being feeling down. And we don't really look very closely at the fact that, the mind and the brain are sort of in there together. And so you can have those kinds of depressive symptoms and anxiety symptoms, but you can also have a lot of sort of organic function symptoms. So this is just interesting because, and I don't know how well you can see it, so I'll just point it out. This red bear right here is right in the front. That's the prefrontal cortex, and it's the frontal lobe is what does our organization and planning. It's kind of the front office of the brain, where all the messaging comes in, and then we organize it and we decide what to do. So a lot of decision making, working memory, executive function, being able to pull memories and use them for a purpose, attention, focus, concentration, and these are all things that people come to me and they might be struggling with during and after brain tumor treatment. The orbital frontal cortex does emotional and social responding. So sometimes people have social withdrawal. Sometimes they find that it's more difficult to be around people, or that the people that they were friends with before, they're having some difficulty in their interactions. The interactions aren't the same. This is the area, this green area is the part that does that. The temporal lobes are the ones that do both memory retrieval and taking input from our sensory system and making meaning of it. So if we're a little bit more sensitive to stimuli after treatment, if we're a little bit more irritable when there are loud noises, if we can't go to a baseball game anymore because there's too many people or it's too loud. These are things that are due to changes in this part of the brain. Cerebellum does our balance, it's in the back, that really, but it also has effects on working memory because it has, it contributes some input based on muscle memory. And it also, this is something that we don't think about, but the cerebellum also helps with mood regulation. So a lot of people talk about how their moods kind of come out of nowhere, and we don't really think about it, but the cerebellum is involved in that, as is the amygdala, this tiny little purple bit. So these are parts of the brain that can be affected, and then we can have symptoms that are not really exactly correlating with anxiety or depression, but are severely impacting our functioning. So I think it's good to know that that these can exist, and that, you know, if this is happening, it's not our fault. We're not getting stupider. We're not, we may not necessarily have a dementia process going on. We may actually have some difficulty with functioning based on which one of these areas of the brain has been impacted by treatment. This slide I'm going to skip because it's a little complicated. Chemo brain. So everybody asks me about chemo brain, which could also be called radiation brain, treatment brain, any kind of treatment brain, surgery brain. So these are the things that people talk about when they're talking about chemo brain. They talk about memory, executive function, processing speed, and attention. And these are things that can be impaired. I'm going to talk about studies that are in breast cancer, and that's simply because breast cancer has some of the most robust research in this area. That doesn't mean that it doesn't apply to brain tumor patients. It certainly does. 33% of women in a breast cancer cohort exhibited cognitive impairment. And findings have shown that patients can have subtle defects across multiple domains. And the word subtle is really important because patients will go to the doctor and be like, I'm not the same, I'm struggling. And the doctor will be like, well, no, I mean, if you look at the testing, you're doing okay. People are comparing themselves to who they were before. So these subtle changes may not be evident in terms of sort of, you know, a frank test result, but to the patient themselves, it's a change in functioning, and that makes it important, at least to me. Memory, executive function, concentration, attention, and processing speed. Again, this really is what we were talking about with the frontal lobe. So that's something that has been reported. I like to use this study to show that some of this is real. They did a twin study, and they chose monozygotic twins, one of whom got breast cancer and underwent chemo, one of whom didn't. They evaluated using a bunch of testing, standard neuropsych testing, and these functional MRIs that light up bits of the brain that are working or not working. And the neuropsych testing didn't show much. So when you go for neuropsych testing, there wasn't much of a difference. However, when you look at the self-reported complaints, i.e. again, the patient themselves is saying something is wrong, or when you look at the MRI images, there were striking differences. One really important point is that these women were postmenopausal, and that's important because, and this patient was only given chemo. That's important because if they're postmenopausal, we can assume that they were kind of around the same estrogen level, because estrogen makes a huge difference for cognition. So that would have been a confounding factor. But because they chose postmenopausal women and they chose a woman who was not going through hormonal treatment, only chemo, that really narrowed it down to the chemo being the factor that changed things. So if you look at their brains, two 60-year-old twins, and the colored areas are areas of the brain that are sort of lighting up and therefore active, and they gave them tasks that were increasingly difficult. This is the first twin, the one who got chemotherapy. Sorry, I'll do it over here. This is the first twin, the one who got chemotherapy. This is the twin who did not receive chemotherapy. Now, at first, you're like, wait, look, the one who got chemotherapy, the brain lights up more. That's not necessarily a good thing, because it means that that twin required way more activation of way more areas of the brain to accomplish the same task as someone who did not get chemotherapy. There's a huge difference between these if you look at them. So what does that mean? It means that we have to recruit more of our brain, which means that a simple task is going to be more tiring to us than it is to someone else. And it means that for more difficult tasks, the more difficult the task gets, the more we're going to sort of pull at the bandwidth of the brain, and our ability to do really difficult tasks may not be as good as the twin who didn't get the chemo. And I think patients find this to be true. Frontal executive functions are the most commonly affected domain, or the one that patients complain about the most because they notice it. Also attention, short-term memory and learning. Usually long-term memory is intact, and speed of information processing. And the information processing one is one that gets missed, I think, because people are eventually able to surmount the difficulty and do the tasks they were able to do before. It's that amount of effort that had to go in because the processing speed is slower and it's taking us a lot longer to do the same thing. That's the part that the patient is feeling, and other people are like, well, you got it done, and they don't really see it. So I think that's important to recognize and acknowledge, because it's a huge source of frustration for patients. And speech and language functions, of course. Now, the other problem is personality changes. I've had patients come to me, or their spouses come to me and go, look, I don't know who this is. He's just so different. This is not the person I married. And we can have more impulsivity. We can be more irritable. And by irritable, I don't mean that you snap once in a while. It's an irritability of both affect, but also sensory irritability, where things irritate us more. It's kind of like being extra sensitive or having a rawness to you all the time. Affective instability. So that means we cry at the drop of a hat, we get angry at the drop of a hat, and we don't really have a lot of control over that. And when we're looking at why we did it, we feel a little bit like our response did not meet the trigger. So a little bit overblown maybe in our responses to things. Apathy. So this goes in the other direction, where we just don't care about anything anymore. And we're sort of affectively flat. And that's a different direction that the brain can go. And a lack of awareness of the deficit. Sometimes people around us are telling us, you're different, you're snapping at me, what's going on with you? And we possibly can't see it. And some of that is coming from that social part of the brain that is not able to see the cause and effect of our behavior. And this I will skip. So what is the normal in terms of behavioral homeostasis, in terms of whether stress itself can be affecting our brain, the stress of the illness? Our human brains are very good at acute stressors. We are really good at running away from a tiger or a mastodon. For that level of stress for a very little period of time, our brain is very good at using the stress to adapt really quickly. And we had to, otherwise we wouldn't survive. However, when the stress becomes more prolonged, we go in the other direction. It starts to have a negative effect on the brain. Our behaviors can become a little less adaptive and a little bit more sort of unhelpful to us. And our goal-directed actions, meaning us making a decision about a problem and then fixing it, may not be effective for a chronic stressor. So when our brain tries to do things to solve the problem and the problem doesn't get solved and it continues to be there, that's when things like anxiety, depression, and trauma come into play. And the treatment often addresses reducing the reactivity to stimuli. So for example, if we are very, very stressed over a long period of time and now we've become anxious, I can treat the anxiety and the anxiety gets brought down, or I can treat the depression and that gets brought down by medication. However, when we do that, we're not always addressing the other domains that were affected, all these things we talked about in terms of cognition. So it's really important to consider that even if we treat anxiety and depression, there may be deficits in other areas. And this is one of the differences between depression and anxiety in a cancer patient versus a patient in the general psychiatric population. So these are some of the areas that get missed. Mood regulation is not the same thing as depression or anxiety. Mood regulation is really being able to react appropriately and not overdo it or underdo it. Being awake, alert, and oriented versus being in bed and being sleepy all the time. Our thinking and reward behavior, meaning we are interested and motivated. Sometimes that system also is not responding. So this is just a slide that talks about some of the symptoms of depression. You can see that they're not just mood related. There's a lot of symptoms that actually have to do with our body and our functioning, including sleep and weight loss or gain. And anxiety, and I like to say that anxiety likes to make itself known in the body more than depression does. So anxiety, you really feel it. You can have muscle soreness, tension, palpitations, edginess that feels like an inner restlessness in the body. So including, the excessive anxiety and worry are there, but there's also a lot of symptoms that live in the body. And this is something that I say all the time to patients. Anxiety and depression affect the mind, but they live in the brain. So when we're talking about brain tumors, it's not a shocker that we would have some of these symptoms when we're trying to treat the tumor. If the rest of the brain is struggling, the reality is we're sharing space, so that can happen. And depression lives in all these different places in the brain. And anxiety lives more in the cortex, depression more in the prefrontal cortex, amygdala and hippocampus and thalamus. This is not really important in terms of anatomy. It's more important to understand when you treat the brain tumor, you affect all these areas of the brain, and anxiety and depression can be a result of that. And so can the cognitive issues. Okay. And then, so people always ask me, what can we do about this? Like, how do I get my brain better? First and foremost, I think that there needs to be an understanding that sometimes you can start with behavioral interventions like exercise and better sleep and more socialization or therapy. But sometimes things have gotten so bad that we actually have to go backwards. We have to start with the medication, get you feeling better, and then I can start to push you. And I'll get really mean and I'll say, listen, now that you're better, you should be exercising, and we got to get on this. Or we need to be eating better. We need to nourish our body. So I think that one of the things people don't recognize is they'll be beating themselves up over not doing as much as they can health-wise to help themselves. Sometimes, until we treat the brain and the mind, we can't do the rest of it. So I think I really like people to keep that in mind. And then many of the medications I use are actually off-label in their use in brain tumors. Brain tumors in particular are difficult to treat psychiatrically because we have to be very careful what we use while people are in treatment. And the whole idea is that we're providing neurotransmitters to the brain when the brain is struggling, kind of like crutches when you break your leg. And the idea is to heal the brain and then have the brain be able to move off. And the last thing here is that in Pacific Neuroscience Institute, we're actually looking into psilocybin and other psychedelics. Psilocybin, to me, is the one that is most suited to brain tumor patients. It's a psychedelic that comes from magic mushrooms, and it's very benign in terms of drug interactions, very benign in terms of side effects, and that makes it extremely well suited to be used in brain tumor patients. And if we were going to use it, we would be trying to sort of help people get unstuck and allow their brain to sort of find some peace, find a feeling of being okay, whether or not they're going to survive. And it really sort of ties in with what palliative does, which is whether or not we're going to be here long term, making sure that the days that we have pockets of joy and are lived well. So as much as possible. So yeah, that's my talk. That's kind of what psycho-oncology does and why we do it. And I will give it back to Anna and I'll stop sharing. Thank you.
First question is for Dr. Garinathan. It says, my daughter has astrocytoma and she had a seizure. She was started on a medication and it changed her. She's just a different person. She's angry. She gets upset. What I think it's because of the medication. And she says, what should we do?
Talk to your neurosurgery and neuro-oncology team. So I think that it's very important to prevent seizures. We definitely want to be doing that. And if your daughter is on a medication, it's because the team has deemed that she may be higher risk for seizures. I will say, though, that as a psychiatrist, I spend a lot of time bugging neuro-oncology and neurosurgery doctors and asking them to please switch the medication, because there's certain anti-seizure medications that are great for seizures, but have a higher incidence of psychiatric side effects. And that doesn't mean that everyone's going to have a psychiatric side effect, but when they do, it can be like this, where you almost don't recognize the person because the medication is changing behavior. And so that doesn't mean that the patient doesn't need seizure control. It means that we need to choose a different agent. It just basically is a way of not tolerating that particular medication. And then all we do is switch to a different medication that can do just as good a job of helping with seizures.
Then this question is for Dr. Gary Nathan. It says, my wife has a brain tumor and she couldn't work anymore. We have financial problems, and I know not being able to contribute financially has made her feel down. I'm not sure how to help her.
Man, that's a doozy. Okay, well, I think that people tell themselves stories all the time, and one of the ones that I can relate to a lot is people who were used to being very functional and very productive and taking care of others. They talk a lot about like, well, I don't want to be a burden. And if our identity, and I think most of us who are caregivers, most of us who work in the hospital and work with patients, our identity is somewhat wrapped up in our ability to help others and our ability to sort of productively give back. And so when people like us or your wife get sick and we can't do that, it's almost an identity crisis, right? Like we don't know who we are. We've never been a sick person before. We've never been in the role where we have to ask for help, or where, a lot of times the narrative is something related to being a burden, needing help, having to ask for help, that these things are not okay and don't sit well with the person. It's different for everyone, and I don't know your wife, but I think that the first thing is I would really talk to the person about how they're looking at it, and how right now it may not be possible for the person to work, but it is possible for the person to really bring joy to others just by being there. And the days that she's well, I'm sure, bring you guys much joy. So cancer is always going to be a change of mindset. Cancer is always going to make us think and have to rework things. And it's important that we do that. It's important that we don't apply our pre-cancer notions to what we're going through during cancer and after, because I think that's a good way to get very down. So I think one of the things that you can do is just talk about how right now it may feel like you don't have what you used to have, but that doesn't change your value. And then also finding ways of finding joy while we're going through this process. And that's easy for me to say, I know, and really hard to do, but I think that those conversations are really important, and understanding that things are a little different right now and we have to manage expectations is important.
Next question is for Dr. Gary Nathan. It says, my son was a go-getter. He was the funny guy in the family, and I know that treatment can make him tired, but I just don't see him the same. It's like he's lost his joy.
Okay, so I'm assuming the question in there is that what has happened and what do we do about it? I think the use of your behavioral health specialists, the people who work in cancer and who understand what is going on or what could be going on, that's what's important. I think as a mom, because I am a mom too, and I have sons too, and we can't always see clearly what someone is going through. They may not tell us. The relationship between the parent and the child makes it so that sometimes things are a little more clouded. We love them, but that love kind of can get in the way of helping them. So I think you can be really supportive, but I think the best thing is to encourage him to speak to someone and get some help, whether that be a therapist or a psychiatrist. Sometimes, like I was talking about in the talk, sometimes it is depression, but sometimes there are cognitive issues that get in the way. There are cognitive issues that, again, can cause apathy, which is this like flatness where nothing brings us joy. We're not necessarily sad. We're not necessarily depressed. So if you say to him, are you depressed? He'll probably say no. But we're not able to sort of express motivation, show interest. it does mimic symptoms of depression, but it's not necessarily depression, particularly in brain tumor patients. I would say in other patients, it's a little bit more likely that it's depression, but in brain tumor patients, we really can't say unless we talk to the patient, look at where the tumor is, look at the treatment, and then understand what's going on in the brain. So I think the best thing to do is to be supportive and non-judgmental and understand that this is organic sometimes and can't be helped. It's not a volitional thing or a lazy thing or a weak thing. And then also get them help.
Is there anything else besides psych meds or seeing a shrink to help my depression?
Oh man, we're calling me a shrink now, huh? Okay, well, I don't blame you. Not everybody wants to add another doctor to the list or add more medication to the list, and especially when we're in active treatment. And the brain is so sensitive to changes that I think the one thing that's to our advantage is anything that we improve, lifestyle wise, medication wise, anything that we do, the brain can respond to that. So I would say, looking at the med list and seeing if any medications that you're taking that might not be as necessary or could be switched, where you're having side effects that are possibly psychiatric or psychological. Another huge one that I really believe in is nutrition and exercise. Now, exercise is not always possible depending on where we are in treatment or how debilitated we might be feeling at that moment. But if you can find little ways of maybe even being outside, that can help. I always tell people go in search of a breath of fresh air. So if that means you do it in a wheelchair, well, that's what that means, right? Or if we can sit at a window and that's about all we can do right now, then that's what we do. But I do think that trying to be outside, trying to be near nature, exercise if you can do it. Nutrition is big. The brain is very sensitive to nutrition. And if you can nourish the brain, that helps. Again, the caveat being if we're nauseated or we aren't able to eat and we don't have appetite or we don't have taste, then those things become difficult. But for every, deficit that we may be experiencing at that moment, there's a different opportunity. There's somewhere else where we can really make an impact. So really looking at yourself and saying, okay, I can't do this and I can't do this, but what can I do? What is within my reach? And it might be something teeny tiny, like sitting by the window, but you'd be surprised how doing one small thing for yourself really can be helpful. And sort of send a message to our brain that we are trying and we are helping ourselves. And so I advocate for any small or large change that might help in your life behaviorally. And then also things like nutrition and sleep and exercise if those things are possible. And hopefully, at least one of those things is possible for whoever is thinking of doing a sort of a non-medication approach. And I'm all for that, and then if that doesn't work, then you can come and see me. And then I'll make fun of you because you called me a shrink. Thank you.
Thanks, Dr. Garinathan. So I think we have one more time for one more question, and this is for each of you. As a person who may have been newly diagnosed with a brain tumor, what is one piece of advice that you could give them to help them on their journey?
I think it can be really hard in the beginning because we have these expectations of like, okay, if I do this just right, then I'm going to be able to fight this tumor. And so there's this tremendous amount of pressure to go to every doctor and every appointment and listen and make these decisions. And it all has this like tremendous import. So what I tell people is that your doctors are there to guide you. Nobody goes into this wanting to in any way not help people get better, right? Like if you go into cancer, I mean, we're all very, very passionate about this. So I think find the doctor you trust. Find the doctor where when you're in the room with them, you're not questioning what they say in your head. And when you leave the room, you feel heard. And if you do that, then you can delegate some of that decision making without being so frightened. And I think that sometimes people stick with one doctor and maybe that doctor isn't quite right or they're feeling unheard or they don't quite trust that doctor. And you don't have to do that, especially in, maybe other areas, but in LA, we're so lucky. There's so many doctors and so many institutions. I think if you find people you trust, I think it makes it a lot easier to make those decisions. And it makes it a lot easier because you feel like you've got a guide with you. And I think people underestimate how much that can really help, especially in the beginning when we know nothing about what's going on. So find people who love their work, and you walk into the room and you feel like this is someone I can trust. That's huge, I think. Thank you.
That's all excellent advice. Thank you so much. And I think just one piece of advice for those out there is, from me, is that share how you feel. Share how you feel. Be open. Do not be afraid to share how you feel. If there's something that you're missing or that you need, or you're not sure even where to start, talk. Talk to anyone. You can talk to your medical assistant, to your nurse, to your nurse practitioner, to your PA, to your doctor, to your social worker. We're all here to help you. And with that, we'll go ahead and conclude this presentation. Thank you so much to our presenters for their gift of time and for this valuable information on palliative and supportive care and mental health for people with brain tumors and their loved ones. Thank you to all the attendees for participating and asking engaging questions, as I'm sure this recording will be helpful for others as well. As you know, much of this work would not be possible without philanthropic support. So thank you in advance for considering how you might be able to support this effort.